Hi, this is Dr. Potasic, and I wanted to do a little bit of an overview for the slides for Chapter 58, just because there's a lot of good information and I was able to condense the slides down some, but I wanted to help you focus a little bit just because it can be a little bit overwhelming when there are so many medications and so many different conditions covered. Headache is probably one of the most common things. We don't even necessarily always think of it as a neurologic problem per se. It's actually considered to be one of the most common types of pain possibly experienced by humans. Functional headaches would include migraine headaches or tension or stress type headaches. The pain sensitive structures in the head that make a headache so miserable are the venous sinuses, the dura, those cranial blood vessels, and then the divisions of the trigeminal nerve with the facial nerve, glossopharyngeal, vagus, and cervical nerves. So primary headaches are not caused by disease or some other medical condition, so tension type, migraine, or cluster. Secondary headaches are caused by another condition or disorder, so when you have a sinus infection, a neck injury, even a brain tumor that might cause a headache. When we look at those tension type or stress headaches, this is really the most common type of headache. They're characterized by usually being bilateral and having a pressing or tightening quality, usually mild or moderate, and tend to be episodic or chronic. Looking at the etiology or pathophys, they're neurologically fairly similar to migraines, can evolve from episodic to being more chronic, but the increased frequency does not necessarily mean that they're going to be more intense. The manifestations, again, are that bilateral, frontal, occipital headache, described as a constant dull pressure or a band-like headache, usually associated with neck pain, increased tone in cervical neck muscles, so tightness, can involve photophobia or phonophobia, so sound and light problems, but there's usually not any premonitory symptoms, so not like an aura or anything. Diagnostically, we just look at the history. There might be some increased resistance to the passive movement of the head, tenderness of the head and neck, possibly an EMG might be done. When we look at migraines, these are recurring, usually unilateral, and there often are premonitory symptoms or triggers, such as an aura or a certain trigger that needs to be avoided. Onset is usually around age 25 to 55 and affects about 12% of the population. So risk factors include being female, having a family history, your age, obesity, lower levels of education for some reason, depression and stressful life events. And there's two categories. So without an aura, which is the common migraine, or with an aura, which is the classic migraine. So those are a little bit difficult to tell apart, I think. The etiology is essentially that there's neuron hyperexcitability in the cortex, especially the occipital cortex can have genetic factors, but in many cases there's no known precipitating events. Clinically, you'll see those premonitory symptoms such as sensory experiences, sleep, mood, or cognitive changes, or even homeostatic changes. There might be an aura, so visual symptoms and distortions, or sensory or motor phenomena, and again, usually that throbbing unilateral pain. Diagnostically, we're looking at history. Usually there's not going to be any imaging done unless there's an abnormal neurologic exam, and not specifically any lab or radiologic tests. So the cluster headache is the most severe primary headache, usually repeated headaches occurring at the same time of day or night, onset ages 20 to 50, and these affect men more than women. It's usually, again, unilateral, and the pattern suggests dysfunction of the hypothalamus. So triggers can include alcohol and strong odors. Some of the manifestations are sharp stabbing or intense pain that can last minutes to hours, might occur every day or as often as 8 times a day, and the cluster might last 2 weeks to 3 months and then go into remission. So that's diagnosed again by history because of that recurrent pattern. So you can see in this graphic some of those headache pain locations. When you're looking at the tension, you're usually seeing that band as the most frequent, and then the less frequent is kind of over the top of the head and the occiput. When you're looking at the migraine, you're usually seeing that intense one-sided, often temporal. You can see the less frequent and least frequent sites too. I'm sure if the pain radiates, that can be a little bit more difficult to assess. Then when you're looking at the cluster, a lot of times it's behind one of the eyes that it starts and then kind of encompasses the whole side of the face. So again, tension headaches, usually the patient will describe as feeling like a weight or a band on the head. Migraine, often unilateral in the temple, can be bilateral, and cluster headache tends to be focused around one eye. So then there's other types of headaches that maybe aren't generated by the typical headache triggers. So these can be a symptom of serious illness. Can be a subarachnoid hemorrhage, brain tumor, other sort of intracranial mass. Can be a vascular abnormality. Trigeminal neuralgia causes a headache. Diseases of the eyes, nose, and tooth, or other systemic illness. And these really require a thorough clinical evaluation. We need to look at personality, life adjustment or changes, environments, living situations, and any neurologic or physical conditions that might be causing this. So when somebody doesn't have a history of headaches, this is a new pain, that kind of thing, we really need a good assessment and, not just to assume it's a typical tension headache. If there's no systemic disease that's causing this, then the type of the headache is going to guide the therapy. So we can have symptomatic treatments as well as preventative therapies. Some of the symptomatic and preventative therapies can be drugs, medications, yoga, biofeedback, cognitive behavioral therapy, and relaxation therapy. When we're looking at the tension type headache and we're looking at that symptomatic treatment, we can look at aspirin, acetaminophen, NSAIDs, etc. But some of the preventatives can be antidepressants or anti-seizure medications. There's a table in the text that outlines a general workup for a patient with a headache to help rule out any inner or extracranial diseases, and then summarizes some of the current therapies for prevention and management. When we are looking at interprofessional care in headache, for the migraine, we want to stop or decrease the symptoms. And so for a symptomatic mild to moderate headache, NSAIDs, aspirin, and caffeine-containing analgesics like an Excedrin might help. When we're looking at moderate to severe headaches, the triptans are usually the first line of therapy because they can impact the serotonin receptors, reduce the inflammation of the cerebral blood vessels, and produce vasoconstriction. Then when we're looking at trying to prevent migraines, we look at the frequency, severity, and disability for that person and look at anti-seizure drugs, beta blockers, also sometimes Botox. Looking at those cluster headaches, again, triptans can be considered, but they'd be contraindicated for patients that have vascular risk factors. Oxygen can help, so the patient needs to have continuous access to it if that's going to be their treatment plan. But when we're looking at preventative, we're looking at verapamil, sometimes nerve blockers or ablations. I've definitely seen verapamil used, and I'm sure that that's maybe a little bit, it's an older drug, so it's possible that that's not as common anymore, but looking at the other headaches, when we look at the analgesics, we can have the risk of overuse of medication and having rebound headaches. And, some of us have probably seen that where you take something, particularly with the caffeine containing drugs, and, it fixes your headache, but then it comes back with a vengeance. So another thing to consider when we're looking at that. When we're doing an assessment, we want to get a good health history. So any history of seizures, cancer, is the person menstruating currently or at that age, exercise, food, bright lights, other noxious stimuli, any medications they're taking, surgery, and other treatments. Then we need really specific details about the headache, the location, the type of pain, onset, frequency, duration, and relation to outside events. So we want to have the best history we can on that headache to know what other testing is needed. Some of the objective data we're looking at would be anxiety, diaphoresis, pallor, flushing, etc. When we're implementing our nursing care, we're going to be looking at things like inability to cope with daily stresses, looking at the daily routine and trying to figure out triggers, incorporating some exercise or relaxation periods possibly. So we can suggest that relaxation, yoga, meditation, talk about those preventative treatments, encourage some quiet and dim environments, massage, hot packs, things like that may or may not help. And the patient wants to make a note of medications and remedies so that they know what they've taken and don't accidentally overdose, and also so that they know what works or what seems to work at what times. Then we want to teach our patient to avoid the triggers, whether they're foods, odors, etc. Moving into seizure disorders, this is an uncontrolled electrical discharge of neurons, and so it interrupts normal function. It can accompany other disorders, or it can occur without any apparent cause. From systemic and metabolic problems, those are not really considered a seizure disorder if the condition being corrected stops the seizures. So some of those metabolic problems that can cause seizures would be acidosis, hypoglycemia, hypoxemia, water intoxication. So that sodium level is very important, alcohol or barbiturate withdrawal. And then extracranial disorders that can cause seizures include lupus, diabetes, hypertension, sepsis, etc. There can be a lot of possible causes, and the most common causes really vary by age. So in the first 6 months of life, a severe birth injury or a congenital birth defect that involves the CNS might be a cause, infections, or inborn errors of metabolism. So all those things that we test for with infants, can possibly be causes of seizures for them. 2 to 20 years, we're looking more at birth injury, infection, head trauma, or genetic factors, especially in that kind of 2 to maybe age 8. I'm always thinking that infection, that febrile seizure, they may or may not ever have a problem again, but certainly a little different than what we're looking at with those 6 months. And then after age 20, we're looking more at structural lesions, trauma, vascular disease, and after 50, more stroke or brain tumor risk. About a third of cases are idiopathic, so not attributable to a specific cause. They call this idiopathic generalized epilepsy. There's just a group of abnormal neurons that seem to fire without a clear cause. So that firing then spreads to near or distant areas of the brain and causes the seizure symptoms that we see. So localization of where that seizure focus is critical to any surgical intervention possibilities. And then changes in the function of astrocytes might play key roles in recurring seizures. So astrocytes are those glial cells that make up the majority of the central nervous system. They regulate the blood-brain barrier, they clear excess neurotransmitters, and they promote formation of synapses. So activation of those astrocytes by hyperactive neurons can cause nearby neurons to generate an epileptic discharge. And so that's why localizing that area is so important. There can be a genetic link. Sometimes genetic abnormalities may be an important factor contributing to idiopathic generalized epilepsy. Some types of seizure disorders run in families, and other types are related to changes in genes. So some of the clinical manifestations of seizures are pretty much determined by the site of that electrical disturbance. There's 3 major classes: generalized, focal, or unknown, and they can occur in multiple phases. So prodromal, oral, ictal, and post-ictal. In the prodromal phase, sensations or behavior changes may precede a seizure by several hours or even days. In the oral phase, the patient might have that sensory warning that's the same each time a seizure occurs, and that's actually considered part of the seizure. Ictal is that phase from the first symptoms through the end of seizure activity, and then post-ictal is the recovery period after the seizure, and it's pretty common to have profound fatigue. So one type of generalized seizure is tonic-clonic. This is characterized by loss of consciousness, falling to the ground, and that stiffness or the tonic aspect, and then subsequent jerking of extremities or clonic. Cyanosis, excessive salivation, tongue or cheek biting, and incontinence are pretty typical. I think of this as kind of what you'd call your classic seizure, or what you'd expect a layperson to think of as a seizure. The post-ictal phase has muscle soreness and fatigue. The patient might sleep for several hours, might not feel normal for hours or days, and most of the time they don't remember the seizure at all. Absence seizures are a little more interesting because they're characterized by a staring spell with eye blinking, jerking of the lips, pretty mild signs that wouldn't necessarily be obvious to just everyone, but usually last more than 10 seconds and usually continue into adulthood. And a lot of times when a patient starts having more obvious seizures, upon doing their history, we'll find out that they may have been having some absence seizures as well. I know a friend's daughter who started having seizures just around age 14 or 15, which is not the most common. They thought could be a little bit genetic because there's some family history of migraine. But the biggest thing that they found was that probably she'd been having some absence seizures for quite some time prior to the first obvious seizure that she had. A myoclonic seizure is rhythmic arm abduction, about 3 movements per second, leading to progressive arm elevation, usually lasts 10 to 60 seconds. There's eyelid myoclonia, which refers to jerking of the eyelids. So you can see that this is a very localized type of seizure, even though it's considered a general seizure. So the focal seizures used to be called partial or partial focal, and this is the other major class of seizures. So focal onset begin in a specific region in one hemisphere of the brain, and then they're producing their manifestations based on the function of the area of the brain involved. And so they're determined by awareness or inawareness of the seizure. When we're looking at general onset non-motor seizures, these are typically absence seizures, usually only in kids and rarely beyond adolescence. It might stop as the child matures, or it might evolve into another type, and that's usually a brief staring spell that lasts less than 10 seconds as compared to our other absence seizures. Looking again at the focal seizures, if they're an awareness seizure, the patient is conscious and alert. They might have unusual feelings or sensations, such as sudden unexplainable emotions, or have some sort of aura where they're hearing, seeing, smelling, tasting, or feeling things that maybe aren't there. When you're looking at that impaired awareness seizure, there's a loss of consciousness or at least a change in awareness. The eyes are open, but they're probably not interacting. They might do things that can be dangerous or embarrassing, and after the seizure, they aren't going to have a memory of it. This is something I witnessed with a friend. I had no idea that she had had seizures when she was quite young, but when we were about 16 and going to a camp, she was just having some ear pain, and so we had a doctor's appointment before we went to camp, and as the doctor was kind of cleaning out her ear and examining it, she had a seizure on the table. Very brief, but kind of a typical sort of no memory, eyes open but not interacting type of focal seizure, and determined that she probably had kind of a low-grade underlying seizure disorder, and we hadn't had a lot of sleep. There was the stress of having her ear cleaned out, which is a little bit painful, and so some of those things turned out to be triggers where if she was sleep deprived, she might have a seizure, and they could be pretty mild and brief. Had we not been in a doctor's office, it may not have even been that noticeable, depending on what kind of activity she had been doing. So the motor activities can be atonic, tonic, clonic, myoclonic, or spasms. There can be just strange behaviors, purposeless actions, or those non-motor activities can be the emotional manifestations, strange feelings, or symptoms. So these can be a little bit dangerous if the patient appears to be alert and nobody realizes what's going on, but they're not really able to interact or make good decisions. Then there's something called psychogenic seizures, and these can be misdiagnosed as a seizure disorder. Basically, this is something psychological causing what appears to be seizure activity. So proper diagnosis usually requires EEG monitoring, but with use of video so that a neurologist can see what's happening as well as see the tracing at the same time. Sometimes there's a history of an emotional or physical traumatic event that might emerge when this is explored. So complications of seizures, why is this a problem? There can be status epilepticus, which is the state of continuous seizure activity where seizures either recur in rapid succession without return to consciousness, so lasting longer than 5 minutes. This is a neurologic emergency, and it can really occur with any type of seizure. So that's one of the biggest concerns. And this status epilepticus is causing the brain to use a lot more energy that's supplied. So the neurons are excited and not getting enough oxygen to carry out the normal functions, and there can be permanent brain damage. So that's why we're always trying to control seizures. Convulsive status epilepticus is the most common form, so this is prolonged or repeated tonic-clonic seizures, and this can, of course, lead to fatal respiratory insufficiency as well, hypoxemia, acidosis, etc. If you have non-convulsive, there can be long or repeated focal impaired awareness seizures, and then there can be refractory status epilepticus, so continuous seizure activity despite administration of first and second line drugs. So that's definitely scary and concerning. You can see how severe injury and death can result from trauma during a seizure. Those patients who lose consciousness, of course, are at the greatest risk. And I thought this stat was pretty interesting. Persons with epilepsy have a mortality rate 2 to 3 times the rate of the general population. Sudden unexpected death in epilepsy or SUDEP is death not related to trauma or other known causes, so typically during or right after a seizure. And so this isn't dying from status epilepticus, this is just somebody dying who has a seizure disorder and probably recently had one or is having one. And so that's not very well defined, but the effect on the lifestyle is, of course, the most common complication of a seizure disorder. There's depression, there's still social stigma, can be discrimination in employment opportunities, and of course, there's driving sanctions many times if seizures aren't very well controlled. So a critical thinking question to which I'm not even going to attempt to address the answer, but what should you do if your patient who has uncontrolled seizures tells you he insists on driving when it's against the law in your state under these health circumstances? And laws do vary a lot by states as far as types of licenses, types of driving, types of seizures, length of time without seizures, things like that. Typically, this is something that's maybe more of a provider issue to address, but living where the majority of us do, we know how critical driving is to independence, to employment. So that can be a really, really big aspect for these patients. And there is hope. There are patients who are seizure free and are able to obtain a license and drive once they are on controlled medications. I know my friend's daughter who started having seizures had just gotten her permit, and so now she's not able to drive for a while. That's a pretty hard thing for a teenager. But I also know a friend of my mom's who had epilepsy and had not had seizures for a long time and was able to drive, was driving her mom somewhere, had a seizure, got in an accident, and her mom lost an eye. And she was just haunted by guilt from that and then didn't drive again after that, even though her seizures appeared to be controlled again. So a lot of considerations with that aspect for sure. Looking at diagnostic studies, we obviously need a good description of the seizures and health history. The EEG might help determine the type of seizure and the focus, but a lot of times patients don't have abnormal findings the first time that they have a seizure or have an EEG. Magnetoencephalography can be done with the EEG, and this gives a little bit greater sensitivity in detecting those small magnetic fields of neuron activity. The typical labs that you would expect to rule out metabolic disorders. CT or MRI might be done in a new onset seizure just to rule out a lesion or a tumor. And then cerebral angiography, spectrometry, etc., might help to determine seizure types. So in the interprofessional care, I always think this part is kind of interesting, but it makes sense. Most seizures don't require emergency medical care. Working primarily in acute care in the ER, I think of seizures as being very emergent, but once we have patients who have a seizure disorder that they're mostly managing, they don't always require emergency care. They are self-limiting typically and rarely cause injury. But you have to be very aware that you need that immediate medical care if there's status epilepticus, there's significant bodily harm, or this is a first-time seizure. So seizure disorders are mainly treated with anti-seizure drugs. Typically, there is not a cure possible, and the goal of therapy is just to limit seizures and have minimal side effects with them. When we give medications for seizures, the goal is to stabilize those nerve cell membranes and prevent the spread of that epileptic discharge. About a third of patients are going to need a combination regimen of medications. The therapeutic drug ranges are guides, and the newer drugs don't require such extreme monitoring for the drug levels, which is helpful. The primary drugs for general tonic-clonic and focal onset seizures are Dilantin, Tegretol, phenobarb, divalproax. Probably all drugs you've administered and seen. When we move into the non-motor and myoclonic seizures, we're looking at divalproex again, as well as Klonopin, and then Zerontin. Lyrica can be used as an additional treatment for focal aware or impaired awareness seizures that aren't successfully controlled. That was something new for me. But status epilepticus, we're giving rapid-acting IV Ativan or Valium to try to reduce the seizure activity right at the time. So a lot of the anti-seizure drugs do have a long half-life and can be taken 1 or 2 times a day. That simplified drug regimen can, of course, increase medication compliance, but we need to be looking at reviewing and adjusting medications frequently as needed. We don't want to discontinue any anti-seizure drugs abruptly because, of course, that can cause a seizure. And the common side effects of seizure medications involve the central nervous system. So, of course, double vision, drowsiness, ataxia, mental slowness, and noncompliance is a concern. And when you look at those side effects, of course, you can see that, as well as the fact that perhaps a patient hasn't had any limitation of driving privileges or work issues or so forth with the seizures. Maybe they haven't had any witness seizures, but if they're taking a medication that they need to list, or that they're worried that their workplace is going to find this out from their insurance, they might be concerned about limitations. And so that could be another risk for noncompliance. When we're doing that neurologic assessment, we also need to test for toxicity of medications. So some of those possible symptoms can be nystagmus, hand and gait coordination issues, decrease in cognitive function or alertness. So some of those side effects that we talked about, but on a larger scale, of course, for a toxicity situation. Looking at gerontologic considerations, many older people might have a first single seizure. They have to have recurring ones to need anti-seizure drug therapy. They're going to be more responsive typically to anti-seizure drugs and also likely to have side effects at lower doses. Phenytoin has some liver function indication or implications, so that can be problematic for older adults who might already have compromised function. And then phenobarb, carbamazepine, and primidone can negatively affect cognitive function, so that's, of course, another concern when you're looking at older adults. So some of the newer anti-seizure meds that can be safer for older adults are gabapentin, lamotrigine, oxcarbazepine, and levetiracetam. I know I'm not saying that right, sorry. Those seem to have fewer effects on the cognitive function and fewer drug interactions. Lamotrigine is probably one of the most common ones I've seen in the elderly population. But again, a lot of times that might be a first seizure they're having, or there might be something underlying. So when we have medically refractory epilepsy, that's patients who don't respond to anti-seizure drugs, and that's about 30% of patients. There's not a good solution for that. Surgery can be an option for some with uncontrolled epilepsy, so that's an anterior lobe resection, temporal lobe resection. About 80% are seizure-free 5 years after the procedure. About 72% are still seizure-free at 10 years. But there's 3 requirements for the surgery. It has to be a confirmed seizure disorder, has to be adequate trial of drugs without satisfactory results, and then defined electric activity so that they can localize that focal area. Some other possibilities are vagal nerve stimulators, can be an adjunct to drugs, especially if the focal point can't be identified, but the exact mechanism of action isn't really known. Might be that it increases blood flow and raises levels of neurotransmitters that help control seizures, and those might change those EEG patterns during a seizure to help kind of reduce the effects. And then there's responsive neurostimulation, known as NeuroPace RNS, and this is similar to a cardiac pacemaker, and it continually monitors the EEG to detect abnormalities and then responds by delivering a precise electrical stimulation. So that's kind of interesting. Biofeedback is another possibility that can teach patients to maintain certain brain waves. Kind of fascinating. Picture biofeedback there. And a ketogenic diet seems to help control seizures. So high fat, low carb, because the ketones pass into the brain and replace glucose as an energy source. So when we are looking at assessing the health history and seizures, there are a lot of things we want to consider. Birth defects or injuries, any anoxic episodes, alcohol use, adherence to medications if they're already on an anti-seizure medication, possible barbiturate or alcohol withdrawal, history of headaches, auras, anxiety, depression, stroke or metabolic disorders. There's a lot of things to assess. It's basically a very comprehensive health assessment. Some precipitating factors can be, and we talked about this a little bit earlier, but that acidosis, hyperkalemia, dehydration, water intoxication, hypoglycemia, etc. So a lot of times you'll see when patients come in with any kind of neurologic deficit and concern, we're checking for hypoglycemia. Is that causing something to do with a seizure or a stroke, or are they acting like they're having a seizure or a stroke because they're so hypoglycemic? So that's always something to be kind of conscious of as well. Some of the injuries and risks that we want to assess for with seizure, bitten tongue and other soft tissue damage, cyanosis and abnormal respiratory rates. Patients can actually be apneic during the ictal phase, might have absent or abnormal breath sounds with that. We need to look for airway occlusion because of how they're positioned, or in the post-ictal stage, how relaxed they are. Is their tongue falling back? Look for hypertension, bradycardia, tachycardia, bowel incontinence, salivation, urinary incontinence, all of those things that might happen when you lose nerve control. When we're assessing general and focal seizures, that tonic-clonic, we're going to see that loss of consciousness, muscle tightening and jerking. Usually there's going to be dilated pupils and hyperventilation, and then apnea, and then that post-ictal somnolence. If it's focal onset and they're aware, there might be the aura, might be some focal sensory motor or emotional phenomena. But then if it's the impaired awareness, they're going to have that altered consciousness and possibly inappropriate behavior, as well as amnesia of the event. In the acute care setting, we're going to assess and record the seizure details, maintain a patent airway, support the head, turn them on their side to prevent aspiration, loosen constrictive clothing, ease them to the floor if they're not already in a bed. But we're not going to restrain the patient or place any objects in their mouth. That used to be such a thing that you'd see in movies where somebody would put a pen or a popsicle stick in someone's mouth because there was this fear that they were going to swallow their tongue. So essentially, you're just trying to keep the airway open, but you don't want to give them anything that they're going to possibly choke on or bite down on and harm themselves more. You're going to give any ordered anti-seizure drugs, and they might require some special positioning, suctioning, or oxygen after a seizure as well. Like I said, when they're post-ictal and very tired, the tongue can kind of fall back and occlude that airway. You're going to make the appropriate referrals, particularly if this is a new onset thing. Collaborate with all the therapies, and we need to teach our patients then about their risk for seizures and the drug plan for their treatment. In ambulatory care, we're really looking at the prevention of recurring seizures as the major goal. And then we have to provide emotional support and try to help people cope with the limitations that this is going to impose on them. So we need to teach the importance of adherence to medications and what to do if a dose is missed, and teach family members emergency management. Teach them that they're not going to put anything in the mouth to try to help open the airway. Medical alert bracelets might be needed, and referrals to agencies and organizations for support also would be important. I thought it was kind of cool that the textbook included seizure response dogs, so I found an image of a puppy that looks a little bit like a German Shorthair, which is what I have, so I just enjoyed that. We've probably all heard about seizure response dogs. The things that they're essentially trained to do is usually to find help if the owner's in trouble, try to pull objects away that pose danger, or pull the patient away from objects that might pose danger. They can cushion them if they fall, can carry information about their handler for emergency response teams, and just provide that emotional support as well. So I thought that part was fairly cool. Moving into multiple sclerosis, this is chronic, progressive, and degenerative, and it is a disorder of the central nervous system. It's demyelination of the nerve fibers of the brain and spinal cord, and onset is usually between 20 and 50 years. Symptoms a lot of times first appear at ages 30 to 35. When it's diagnosed at 50 or older, it's oftentimes a lot more progressive, and it does affect women much more than men. About 400,000 Americans are affected. It's most prevalent in temperate climates, so up here, there's suspicions that exposure to certain environmental agents, even before birth, might predispose a person to developing MS. The cause is unknown. Some of the possible factors include infections, smoking, injury, emotional stress, fatigue, pregnancy, poor states of health. Can be some genetic components. It is classified as an autoimmune and inflammatory disorder. And there's three processes that really characterize it. So chronic inflammation that leads to demyelination, and then gliosis, which is scarring in the central nervous system. So the primary condition is the autoimmune process, which is driven by activated T cells, which go into the CNS and disrupt the blood-brain barrier. And this might be the first event in the development of MS. And then the subsequent antigen-antibody reactions lead to more destruction of the axons. The attacks can cause damage to the myelin sheath of neurons. The nerve fiber isn't affected, and the impulses still occur, but they're slowed when the sheath is interrupted like that. There might be noticeable impairment of function. The myelin can still regenerate, and when it does, the patient's in remission. As inflammation continues, however, myelin loses the ability to regenerate, and those nerve impulses are disrupted, and the nerve function might be permanently disrupted. So you can see that A is a normal nerve cell with the myelin sheath, and then B is that normal axon, if the node of Ranvier in there, and then you can see the myelin breakdown in C, and then in D, a complete disruption of the myelin, and that axon's not functioning at all because of that. Looking at some of the clinical manifestations, the onset is often insidious and gradual. They're going to have these vague symptoms periodically over months or even years that probably aren't going to prompt someone to seek medical attention. And so the disease is often diagnosed long after the onset of the first symptoms. In some patients, there's chronic progressive deterioration in some patients, and in others, they have remissions and exacerbations. But the overall trend is, a progressive decline in neurologic function. So figure 58.3 here from the textbook shows chronic multiple sclerosis, and there's a demyelination plaque at P at the gray-white junction. I think it's kind of hard to see. And there's an adjacent partially remyelinated shadow plaque at V. So again, I think that's a little bit challenging to see, but certainly a disordered brain in the image. Looking at some of the clinical manifestations, there are a lot in the chart. I will not read them all to you, but some of the first symptoms might include blurred or double vision, red-green color distortion, or blindness in one eye. And, if you consider those types of issues, you have to wonder if they resolve quickly, who's going to go get treatment for them, or who's even going to catch that this could be something more significant than, some sort of visual anomaly. Some of the more common manifestations as time moves on then are motor problems, sensory problems, cerebellar instability, and then some emotional lability as well. When we're looking at those motor manifestations, there's going to be weakness or paralysis of the limbs, trunk, and head. There can also be some spasticity of muscles, scanning speech, where they're kind of looking for their words. And then those sensory manifestations might be even more defined: the numbness and tingling, pain, some decreased hearing or ringing in the ears, dizziness, chronic neuropathic pain. Patients a lot of times describe muscle weakness in the extremities as well as problems with coordination and balance, and can affect walking or even standing. And then speech impediments, tremors, and dizziness or hearing loss can also be found. Lhermit's sign or phenomenon is called Barber chair phenomenon, and it describes a shock-like sensation that occurs with flexion of the neck, which radiates down the spine and possibly into the legs, arms, and trunk. And again, that's something where if it occurs, I don't know that you'd think it was significant necessarily, even if it kept occurring, as long as it resolved when you unflexed your neck. So, certainly little nuggets to kind of keep in mind if your patient is describing a bunch of symptoms and throws that in there with it. So some of those cerebellar things you'll see are the nystagmus, ataxia, dysarthria, dysphagia. They're going to have some fatigue just because everything is so weak and they're trying to still perform their daily activities. And there can be bowel and bladder functions affected. Constipation is common, but urinary problems can vary. You can have a spastic bladder or a flaccid bladder. Some of the cognitive manifestations are short-term memory and attention, as well as information processing and planning. And then those emotional manifestations of anger, depression, and euphoria make a lot of sense, because you would probably have some of those if you're struggling with planning and word finding and your memory anyway. But then you add in kind of that emotional lability of the disease itself, and they're going to be even more obvious. Looking at the diagnostic studies, there isn't a definitive test for MS. It's based primarily on history, the clinical manifestations, and then you would look at an MRI of the brain and spinal cord, because it may show plaques and inflammation and atrophy. You can look at a CSF analysis if you do a TAP, and you might have increased immunoglobulin G or oligoclonal banding. But really, those evoked potential responses are often delayed because of the decreased nerve conduction. So you might see that clinically. But really, they're just looking to see that there's 2 inflammatory demyelinating lesions in at least 2 different locations, and then damage or an attack occurring at different times, usually greater than a month apart, and ruling out all other possible diagnoses to diagnose this. So it's, I'm sure, difficult, as people are probably hoping to find anything else that it might be, when you can't definitively say that it's MS. There is no cure, so the interprofessional care, again, is aimed at treating the process and providing symptomatic relief. And the therapy is tailored specifically to each patient's disease pattern. So early intervention is the most effective. Remember, we said if somebody's diagnosed later, like after age 50, it tends to be much more quickly progressive. So immunosuppressive therapy can slow the progression of the disease, and it can be done with immunomodulators as well as adrenocorticotropic hormone. Those immunomodulator drugs help modify the immune response and progression and help prevent relapse. So we're looking again at beta interferon and some other sub-Q medications. When we're treating the relapsing, remitting forms of MS, there are a couple drugs that help to immunomodulate and provide anti-inflammatory properties or prevent the lymphocytes from reaching the CNS and causing damage. Then for those more active and aggressive forms, there are some newer drugs that, honestly, I haven't seen any of these used, but maybe you guys are seeing them in some of your clinical practice. Probably depends a little bit if you work in neurology. Sometimes general practitioners are not as likely to prescribe some of these more aggressive medications, and probably the patient has sought more advanced care as well if they're having that aggressive form of the disease. Some other possibilities include corticosteroids that might help with acute exacerbation, just because they reduce the edema and the inflammation at that demyelination site. Therapeutic plasma exchange and IV immunoglobulin G can possibly help. And some other drug therapies that are, again, more for the symptoms are muscle relaxants, CNS stimulants, TCAs, potassium channel blockers, and anti-seizure drugs. When we're looking at the interprofessional care, there can be some other interventions. If the patient is very spastic, they might need surgery or a dorsal column electrical stim. Intrathecal baclofen pumps I've seen. I believe it was a patient with MS, if I'm remembering right. Exercise can help to decrease spasticity and increase coordination, and can help retrain the more unaffected muscles to act for those impaired ones. So again, we're taking a health history, and we are looking at viral infections, vaccinations, where they reside, so those cold or temperate climates, medications, any elimination problems, the muscle weakness, fatigue, spasms, vision and hearing issues, decreased libido, and those emotional aspects as well, the anger, depression, euphoria. And there is a table in your book, 5814, if you want to see the subjective and objective data that we want to obtain from a patient. Looking at that objective, we might notice apathy, could even be pressure ulcers if somebody's coming in later on. That scanning speech, tremor, nystagmus, foot dragging is something I tend to think of. Working with a nurse who had MS but was very well controlled, you could always notice it once she had worked several shifts in a row and was more tired, that one of her feet tended to drag more. Certainly not a definitive diagnostic type thing, but just something that a lot of times you will see, especially as patients have more fatigue. When we're looking at implementing our nursing care, we want to help the patient to identify triggers and help them avoid or decrease those effects, and be reassuring during that diagnostic phase and assist them with dealing with the anxiety and grief that's caused by this diagnosis. During the acute exacerbation, we want to prevent those complications of immobility. Pressure ulcers were mentioned before, but blood clots, anything like that, we want to be ensuring that we're caring for our patient, even though they're typically mobile. At that moment, they're immobile, and so they have those risks. We need to focus our teaching on building general resistance to illness, as well as the treatment plan. So they need to be looking at lifestyle changes that might include minimizing caffeine intake, self-catheterization, high-fiber diets to avoid constipation or relieve it, and those emotional adjustments. Those are a lot of big issues and things to consider, especially if somebody has not been thinking that they have something serious going on and comes in and finds this out. So just a quick critical thinking question. Interferon or beta-seron has been prescribed for a patient diagnosed with relapsing remitting MS. Which statement, if made by the patient, indicates additional teaching is needed? So interferon beta or beta-seron is an immunomodulator drug. It's not a corticosteroid. It's given sub-Q every other day. So the patient teaching needs to include that they're going to rotate injection sites with each dose, assess for depression and suicidal ideation. They need to wear sunscreen and protective clothing while exposed to the sun, and know that flu-like symptoms are common following the initiation of therapy. So reducing sodium intake to prevent edema would be more of a concern with a corticosteroid and not with an immune modulator. Moving into Parkinson's disease. This is a chronic and progressive neurodegenerative disorder, as everything else we're covering, characterized by bradykinesia, rigidity, tremor at rest, and gait changes. Affects up to 1 million Americans, and the incidence increases with age. Only 4% of people are diagnosed before age 50. Men are more likely to have Parkinson's than women. The exact cause is unknown, probably a result of an interplay between environmental factors and genetic makeup. In 15% of cases, there is a family history. I found it interesting that the risk is increased by well water, pesticides, herbicides, and rural residents. Many forms of secondary and atypical Parkinsonism can exist from exposure to chemicals. It can be drug-induced from prescribed or illicit drug use, and other causes. I actually remember seeing a gentleman come in who had kind of a heat stroke issue, but also had been working with a pesticide, and they really thought this was an acute chemical exposure, and there probably was some component of that, but he did end up actually being diagnosed with Parkinson's after quite a bit more workup after that. So that was a kind of unfortunate interplay of all of those things as well. Looking at the etiology, it is due to a lack of dopamine. There's a degeneration of those dopamine-producing neurons in the substantia nigra of the midbrain. And so that disrupts that whole dopamine acetylcholine balance in the ganglia, and those are essential for normal functioning of the extrapyramidal neurological system. So the left-sided view of the human brain shows the substantia nigra and the corpus striatum within the cerebral hemisphere, and then the nerve fibers go up from that substantia nigra and go into many branches and carry the dopamine to all the regions of the striatum. And so a deficit in dopamine is creating an imbalance between dopamine and the excitatory neurotransmitter acetylcholine. So they're a little small and hard to see, but in a healthy person is going to have dopamine released from the neurons that inhibits the firing of the neurons that release the GABA. Conversely, the neurons in the striatum which release the acetylcholine excite those GABAergic neurons. And in normal conditions, we want those inhibitory actions of dopamine to be balanced by the excitatory actions of acetylcholine and result in controlled movement. But in Parkinson's, the neurons that are supplying the dopamine are degenerating, so you have that deficit, and then the excitatory effects of acetylcholine are unopposed, and you have those disturbed movements, so tremor and rigidity. Lewy bodies are another kind of type of Parkinsonism. Lewy body dementia is actually covered in a different chapter, but these are unusual clumps of protein found in the brains of patients with Parkinson's. There's an unknown cause, and the presence indicates abnormal brain functioning. And Lewy body dementia is kind of a separate diagnosis, but it does really show very similar Parkinson's symptoms. My husband's grandma had Lewy body dementia and never really was diagnosed with Parkinson's, but all of her symptoms were classic 100% Parkinson's. We couldn't believe that that wasn't the diagnosis. So that's another interesting factor, but those Parkinsonism symptoms can apply to other things. The onset is usually gradual. The progression is ongoing. So unlike with MS, you're not going to see that relapsing remitting. It's going to continuously decline typically. TRAP is an acronym for tremor, rigidity, akinesia, and postural instability. So in the beginning stages, there might be a mild tremor or a slight limp or decreased arm swing when someone's walking. In the later stages, there's shuffling, kind of a propulsive gait with the arms flexed and loss of postural reflexes, and might experience some speech abnormalities as well. That shuffling gait is pretty classic, and you kind of know it when you see it, I think. Tremor is often the first sign. It's usually starts out very minimal, affects handwriting, and is aggravated by emotional stress or, forced concentration. The pill rolling hand tremor, I can only describe as if somebody is rolling a pill in their hand. You'll see this fairly often with later stage Parkinson's patients. I don't know if it's as noticeable in earlier stage. I think it's probably just less noticeable because they're doing other bodily movements. It's more noticeable when you have somebody who's maybe in a nursing home in a wheelchair and is consistently doing that pill rolling. The diaphragm, tongue, lips, and jaw can be involved. Essential tremor is really not associated with Parkinson's disease. Essential tremor is occurring during voluntary movement. It has more rapid frequency and it tends to be familial. So I think essential tremor is more what we're used to seeing in someone, and they don't have to be elderly. I've even seen it in some teenagers and so forth, but it's definitely a more rapid frequency of the shaking, so it doesn't have kind of that initially minimal start, if that makes sense. Looking at the rigidity, there's increased resistance to passive motion. If you're trying to do prom, cogwheel rigidity has a jerky quality, and it's kind of like intermittent catches in the passive movement of a joint. And then there can be some sustained muscle contraction, which is going to result in soreness and aches and pain. And then there's just going to be a slowness of movement because the movements aren't that well controlled. And so there's, extra effort put into controlling it. It's kind of a characteristic look of a patient with Parkinson's disease that you can see. There's that forward tilt to the posture, the short shuffling gait. There can be the tremor, that blank facial expression, and the slow, monotonous, slurred speech. And that's because of the absence or loss of control of those voluntary muscle movements. Bradykinesia is that slowness of movement, and it's particularly evident in the loss of those automatic movements. And that occurs subconsciously and results in those classic characteristics, that masked face and drooling and the stooped posture and the shuffling gait, which is known as festination. So some of the non-motor symptoms: depression, fatigue, pain, constipation, erectile dysfunction, and memory changes. And there can also be difficulty with sleep. Can be hard to stay asleep. Sleep can be restless. There can be nightmares, drowsiness during the day, and REM sleep behavior disorder, violent dreams, and potential dangerous motor activity in REM sleep. And when you think about that imbalance in the brain, some of that makes some sense. Some of the complications increase as the disease progresses. The motor symptoms, weakness, neurologic problems, and psychiatric problems are going to continue to worsen, often results in dementia, and that results in increased mortality. Dysphagia might result in malnutrition or aspiration, and then that general debilitation can lead to pneumonia, UTIs, skin breakdown. Eventually there's orthostatic hypotension and increased risk for falls as well. There's no specific tests for Parkinson's. It sounds like kind of a broken record here if you've been paying attention. Diagnosis is based on history and clinical features, does require the presence of TRAP, usually has an asymmetric onset, and confirmation usually is just that there's a positive response to anti-Parkinsonian drugs. When we're looking at drug therapy, this is aimed at correcting that imbalance in neurotransmitters. They either enhance or release the supply of dopamine, or they block the effects of the overactive cholinergic neuron. So it's an anticholinergic. Sinemet is the primary treatment, which is levodopa-carbidopa. Levodopa is a precursor of dopamine, and it can cross the blood-brain barrier and then is converted to dopamine. And then carbidopa inhibits the acetylcholine from breaking down the levodopa. Amantadine, which is typically an antiviral that we see given like if there's an outbreak of a norovirus, increases dopamine and blocks the reuptake, so that can be an adjunct. The anticholinergics decrease the activity of acetylcholine. MAO-B inhibitors increase levels of dopamine and also prolong the half-life of levodopa, so again, another adjunct. Comtan and Tasmar are newer drugs that block the enzyme catechol-O-methyl translate, which breaks down the levodopa, and so they help prolong the effect of the levodopa or Sinemet. Exelon and Aricept you're probably familiar with for dementia treatment, but they might be used as well to help kind of be a little bit of a preventative with Parkinson's. The amitriptyline can help treat depression. Prefer the use of only one drug because there's fewer side effects and the dosages are easier to adjust. But as it progresses, usually combination therapy is going to be required. Those excessive dopaminergic drugs can lead to kind of a paradoxic intoxication because they have such high levels of dopamine then. And you can have episodes of hypomobility that can occur within like 3 to 5 years of diagnosis. Off episodes can be when they're at the end of a dose and it's wearing off. And so they can treat that with Stalevo or Apoquin. Apoquin has to be taken with an antiemetic. I have seen patients on Apoquin, and I guess I don't recall that they were on an antiemetic, but I thought it was good. Again, kind of nugget to remember. So again, no cure. The interprofessional care focuses on the symptom management. There is surgical therapy that can be used in patients that are not responsive to drug therapy or have developed some severe complications. So deep brain stimulation or ablation or transplantation can be possibilities. The deep brain stimulation is the most common. It's reversible and programmable, and it decreases the increased neuronal activity that occurs because of the dopamine depletion. So it improves motor function and reduces the dyskinesia. It basically involves putting an electrode in the thalamus, globus pallidus, or the subthalamic nucleus, and connecting it to a generator that's in the upper chest like a pacemaker. And it can be used to treat tremors and uncontrolled movements, and the electrodes are surgically connected to that. Looking at interprofessional care, there's also ablation surgery, so they can locate, target, and destroy the area of the brain that's affected by Parkinson's, and that goal is to destroy tissue that's producing those abnormal chemical or electrical impulses that are leading to tremors and other symptoms. So not really treating the disease, but treating the some of the symptomatic aspects. Transplanting fetal neural tissue into the basal ganglia is a possibility. So it provides dopamine producing cells in the brains of these patients, and there's some research and clinical trials ongoing for that. Looking at nutritional therapy, malnutrition and constipation can be some fairly serious consequences. So we need appetizing foods that are easy to chew and swallow because of that bradykinesia and dysphagia. Need adequate fiber and fruit. Consider that eating smaller meals is less tiring than eating 3 large meals each day, and we have to plan ample time for meals. And then levodopa absorption can be impaired, so we have to watch what foods and additional nutrients and vitamins we're supplementing with too. Make sure they're not inhibiting that. Again, in the health history, we're looking at CNS trauma, cerebrovascular disorders, exposure to metals, and carbon dioxide. encephalitis, and then medication history of major tranquilizers, methyldopa, or amphetamines. So we need to get that subjective data from the patient. And then we're looking for some of those objective things such as fatigue, excessive salivation, dysphagia, weight loss, constipation, incontinence, some falls, loss of dexterity, some of that diffuse pain in the head, shoulders, neck, back, and legs because of that excitability, insomnia, and mood swings as well. We're also seeing that blank or masked face at times, dandruff, ankle edema. That postural hypotension tends to be a little later. The tremor at rest or pill rolling tremor often is aggravated with anxiety and then absent at sleep or significant rest. So the more upset a patient might be, you might see an increase in that tremor. Poor coordination, we talked about the cogwheel, rigidity, stoop posture, shuffling gait, all of those things we want to be assessing for, of course. It does not have acute exacerbations or remissions. So we need to focus our teaching and nursing care on maintaining good health and encouraging independence, and then avoiding complications such as contractures or falls. Promoting that physical wellness through exercise and a well-balanced diet, and working with occupational and physical therapies can be important for helping to maintain the independence as long as possible. Looking at the walker picture just made me think of trying to allow the patient as much independence as possible. And I know in the acute care setting that's particularly difficult as we're worried about falling always. But some of the things that we can do to try and help patients with their problems due to the bradykinesia and to maintain that independence can be consciously thinking about stepping over an imaginary object on the floor so they're picking their feet up and having less of that shuffling gait. Walking to a beat, such as with music. This is kind of impressive, watching some of these people who are impacted, dance or just follow a beat. And that one step back, two steps forward, I've seen this done with therapies as well. And it's kind of impressive how well that helps them to propel themselves with more stability for whatever reason. So promoting independence, we want to help them get out of the chair by using their arms and placing the back legs maybe on small blocks if needed, just to elevate that a little bit. Want to take out rugs and excess furniture that could be hazards, and simplify clothing that has buttons and hooks. Maybe go with things that are zippers or even Velcro. Use elevated toilet seats, might want an ottoman to elevate the legs, help to manage the sleep problems. If someone's tired, all of these other symptoms are going to be so much more impactful. And then assist our patients as they make adjustments to their lifestyle to accommodate the symptoms. And consider the caregivers as well. They're going to experience stress associated with the disease progression, particularly when you start thinking about dementia.